Okay, all right, we'll go ahead and get started. Hello, everyone. My name is Elizabeth Benson, and I am the president of the Alabama chapter of the Voice Foundation. I'm here today with a number of my colleagues who are on the chapter council with me, and we are so excited to share with you adolescent voice perspectives today. Before we get started, I just want to make a couple of announcements. We will be having officer elections happening in the next couple of months in our chapter, so please look out for calls for nominations and then also for your participation in the voting process. That will all take place online, but please keep an eye out as that'll be happening before we go into the new year. And we are really super excited today to present two different perspectives on the same topic. This is a format of presentation that we're very fond of here in the Voice Foundation, where we look to do interdisciplinary integration and looking at similar topics from different points of view. And so we're really excited to repeat this format for the second time in the last couple of years, to have a voice teacher and a speech language pathologist both speaking on working with adolescent voices. So I'm very excited today to have Maia Nystrum Braden and Chadley Ballantyne joining us. And I'm going to go ahead and put their biographies here in the chat for you so you can look at all the details. It says my message is too long, and so it's not letting me paste it, but I will paste it here momentarily. We are going to start with Maia Nystrum Braden, who is our speech language pathologist joining us from the University of Wisconsin-Madison. And then we will follow up with Chadley Ballantyne, who's joining us from Stetson University, DMA voice teacher and singer. So at this point, I will turn it over to Maia, and I'll be pasting her bio into the chat for us. All right, take it away, Maia.
All right. Hi, thank you so much for having me here. I'm excited to see so many people joining us on a Sunday night. So I will be sharing a PowerPoint and talking, but feel free to put questions or comments in the chat. And then we will have time for chatting afterwards too. So just give me one moment to share my screen.
Just before we get started, one quick note. Sorry, I forgot a housekeeping note. We will be taking some screenshots of the presentations today. So if you don't wish for your image to appear on any of those screenshots, just go ahead and turn off your video. It's fine to be off as long as you want during the meeting. And thank you so much.
Great. All right. All right, is that sharing okay?
Yeah.
All right. So my part of the talk is adolescent performers, the SLP perspective. So disclosures to start with, I do have a salary from the University of Wisconsin-Madison. I do have an honorarium for this talk, and I do get royalties from MedBridge for a talk on pediatric voice evaluation and treatment. And I'm also a member, non-financially, a member of the ASHA SIG 3 coordinating committee. So what's my background and why is this interesting to me and why do I want to talk about this? So I actually started my career going to school for music. I wanted to be an opera singer, and so I am a classically trained soprano. I realized by about my senior year that I probably wasn't going to make it as a career, but I really still enjoyed singing, and I became really fascinated with the science of the singing voice. And fast forward a few years, and I went back to school for speech language pathology with a specialty in voice. Edie Hapner was actually my CFY mentor at Emory University, and I've worked in a few voice centers over the years. Most of my career was at the UW Health Voice and Swallow clinics at the American Family Children's Hospital, specializing in pediatric voice, especially working with teenagers with injured voices, for one thing. A couple years ago, I made a slight career move, and I now teach at the University of Wisconsin-Madison in the Department of Communication Sciences and Disorders, supervise graduate students in our clinic, and I teach our voice and voice disorders class. So that's kind of how I have come through this career. But I've always loved working with teenage singers. I think it's a really fun group to work with, but also challenging. So what I want to talk about today in terms of what I bring to this as a speech language pathologist, knowledge about the physical changes that happen during adolescence, the changes in the brain that happen during adolescence, what kinds of vocal injuries and vocal health we are focused on in young singers, evaluation and treatment, and collaboration with other voice professionals, because we can't do this alone in a vacuum. So just for our purposes, who am I calling a young performer? I would say any child or teenager who uses their voice for singing or acting. And I would say adolescence for the singing voice extends into college years. So there are still changes going on into the early 20s. They can be professional or amateur. Most of the kids I've seen in Madison, Wisconsin are amateur or avocational singers, but might have aspirations of being professional. And I would include all singing styles and all performing styles. So classical, community theater, choir, rock, gospel choir, church music, extreme vocals, not saying that too much in teenagers, but a little bit. And so anyone who is kind of going above and beyond just speaking with their voice to perform with it. And probably preaching to the choir, but kids' voices aren't just miniature adult voices. They're not fully developed, but a lot of times they want them to be, and they are emulating older singers and asking adult performance from them in whatever context they are. So we have to keep that in mind, that they are not fully developed either physically, emotionally, cognitively, but they really want to be. And so we have to take that in consideration when we think about the risk of injury and vocal challenges that they might have. So I'm going to get a little sciencey. There are tons of changes that occur in the human voice from birth to adulthood. And I'm going to go over just a few of them, especially those that relate to adolescent performers. But the size, the shape, the position, the cartilages, the actual makeup of the vocal folds, respiratory capacity, and neuromuscular control all change. And just for an example of how much things are changing, this is an example of an infant larynx. You know, it's actually much higher up in the throat, and it's cone-shaped rather than cylindrical. This is not the adolescent singers that we're working with, but there are so many changes that are happening, and it happens relatively quickly over a short period of time. So this is just an example, kind of hard to see over here. We've got the baby larynx all the way to the adolescent larynx. So at birth, the vocal folds actually have really limited layer structure. So if you're familiar with the 5-layer structure of the vocal folds, infants don't really have that. And so it takes about 4 years for the layers to develop till there's actually a ligament, a vocal ligament. And about age 7, the lamina propria, especially the superficial lamina propria, that gelatinous layer that is so important for vibration, is near the adult depth, but it still has a slightly different makeup. And not till about age 14 to 17 did we really see that complex adult layer structure. So in our younger adolescents, they may not have the same amount of superficial lamina propria. They may not have the same makeup of tissues. There's not extensive research on what that means for injury, but we do know that vocal injuries look a little bit different in kids and teenagers than they do in adults. And so some of the things that we might see too is, you know, if that superficial lamina propria doesn't have the same depth, what do the lesions look like? Do they have more of an effect if somebody has nodules or a polyp or something like that in that smaller vocal fold? And they tend to take up a larger amount of the vocal fold itself because the vocal folds are smaller. So I think of the voice as kind of a moving target through the childhood and teen years. So it descends from C4, so kind of up here, all the way to C7 by age 15. So it's actually dropping down in the throat. And then the vocal folds get a lot longer, especially in assigned males, but also in assigned females. So infant vocal folds are actually only 3 millimeters long, teeny tiny. I just lost my screen. I'm so sorry. Yeah, there we go. all the way up to an adult male, 20 millimeters. And so again, when we're talking about adolescents, a lot of that change has happened, but not all of it has happened by the time they're, 12, 13 years old. It's also the vocal tract is getting longer as kids grow and as teenagers grow, and especially that rapid change that adolescents are going through. And if you think about a lot of what we do in singing voice, we're adjusting the vocal tract to get the resonance and the tone and the timbre that we want. And if that's always changing on you and that's getting bigger, then some of the things that they start doing when they're small may not work the same way as they get older. And as I talked about the vocal fold structure, that layer structure is not fully mature until 14 to 17 years old. And then we also have motor control and respiration. And I won't get into tons of details on that. Respiration is close to adult when kids are adult size. And actually speech breathing is close to adult by 10 to 12 years. But we don't really know what that looks like for all singers, because I think there's a lot that goes into learning how to breathe for singing. And then there's puberty. So puberty, the earliest onset is pretty young. Between 8 and 13 in girls is considered normal, not precocious puberty, 9 to 14 in boys. And I'm talking at this point about cisgender boys and girls. Getting into transgender kids is a whole different set of hormones and laryngeal development. So we'll focus on what happens with cis puberty at this point. But there are rapid changes happening in the larynx, the whole body. So we'll talk about the range is changing. And anybody who works with teenagers sees frequent difficulty often with register transitions, changing amounts of breathiness, a little bit of difficulty getting good focus to their tone. And as things are changing, they may try to adapt to this in maladaptive ways. So a lot of kids will they'll strain and they'll tense and they'll kind of overuse extrinsic musculature, trying to regain control if things are changing fast and also trying to sound older. And they may find their voice classification is shifting, which may be what they want and may not be what they want. So as we're going through this, sometimes we're having to deal with the emotional piece of it as well as the physical piece of it. So when we're looking at assigned male voice change, usually happens between 10 and 18 years, but the most dramatic change takes about a year. So the vocal tract lengthens, the vocal folds lengthen, they nearly double in length. The thyroarytenoid muscle, the muscle of the vocal folds, increases in bulk, which can change the voice quality. Typically, the lowest pitch will lower by about an octave, but the highest pitch can lower by about a sixth too. So as that's happening, they may actually have a rather large decrease in their pitch range before it gradually grows again. This doesn't happen with everybody, but a lot of teenage boys will go through this where they can't hit their high notes and they can't hit their low notes. And it can be really frustrating and, again, can lead people to do things that are maybe not helpful for their voices. Those passaggio points, transition points can change and be more unstable. And they may notice cracks and breaks both in their speaking voice, which is kind of that typical hallmark of puberty, as well as in their singing voice. And so you have all this happening while kids are trying to perform and continue doing all the things they want to do. We focus on male voice change, but girls' voices change too, right? We know that adult females don't sound like children. And this occurs a little bit more gradually and in kind of fits and spurts throughout puberty. But the speaking fundamental frequency decreases. The vocal folds grow not as much as with male puberty, but they grow about 3 to 4 millimeters. The lower limit of the pitch range lowers about 4 semitones, while the upper limit increases, but it may again narrow before it increases. And those transition points become more unstable for a while. Some kids experience breathiness or huskiness during the transition through puberty. They may have pitch inaccuracy. I think of this in terms of their, it's like if you suddenly gave somebody a full-size cello over a 3/4 size and they're trying to put their fingers in the right places for the notes, when the vocal folds are changing, the respiratory tract is changing, it's hard to be as accurate. And again, they may have some cracks in their speech and singing, not so much as boys, but they often do. And then even after puberty, it's not like they hit puberty and then it's over. The voice continues to develop and change after the voice change. The pitch and tone instability should be resolving, but you can still have this muscle tension. Teenagers often still have difficulty with register transitions, but this should be resolving as their technique develops. Voice classification can continue to change into the 20s. Tone quality continues to change into the 30s, and really through our whole lives, our tone quality changes. But in terms of that developing tone quality, depending on the voice type and style of singing, it may continue to change. And that breathiness that we see in teens usually resolves and should be resolving. So if we're hearing a lot of breathiness that's that they can't eliminate, that's definitely something to look at. Then there's neurocognitive development. So they're not fully adult. Their prefrontal cortex, the part of the brain that is in charge of executive function, so making good decisions, impulse control, thinking ahead, is not fully developed. There's also, I find this super interesting, especially, watching my kids turn into teenagers or get closer to that age, increased risk taking. And part of this is because they actually have increased reward motivation, very, very active dopamine production and use. So if you think about like getting that reward for doing something, that reward versus the risk, they're more likely to downplay the reward and or downplay the risk and go for the reward because of the chemicals going on in their brains. And self-regulation is not fully developed. So emotional self-regulation, planning ahead, thinking ahead about doing things. So you put that together with a rapidly changing vocal mechanism. And sometimes it can be a recipe for being more prone to vocal injuries. And then the other thing is they are supposed to be moving towards independence. It's what they're biologically meant to be doing, is moving away from having being dependent on parents and adults and being more independent and thinking for themselves. If we get into what we know about educational development, cognitive development, they do have capacity for abstract thought. They're developing metacognition so they can think about how they learn and think about how they're thinking. And they have more logical problem solving than younger kids, but it's still developing. So they may not always be as aware of how they're learning. So when I'm working with teenagers with voice disorders or voice injuries, these are the things I really think about, is they need to be involved in their own goal setting. We can't just tell them what they have to do with their voice. They have to be involved in it. They're able to think through and problem solve, and they really want to be perceived as mature, but they still sometimes have poor impulse control. There's also, with teenagers, starting even younger than this imaginary audience. So even when nobody's there, they have this feeling like people are watching them, and that can influence practice, and that can influence willingness to try things. So in a lot of cases, they may have trouble with self-regulation, impulse control, and thinking ahead in the face of short-term benefits. So they may know what they need to do to keep their voice healthy, but they may still find they have trouble doing it. So they know that if they have a concert the next day, they should not be up late talking and being loud the night before, and yet they might still do it because they just have trouble stopping themselves. Okay, so this changing vocal mechanisms, a little bit of breathiness, pitch and register challenges, changing range, these can all be signs of a voice disorder, right? But they can also be a normal part of development and not necessarily pathological. Combined with some questionable vocal decisions and moving towards independence, it can put them in danger of vocal injuries, maybe more so than adults. And sometimes it can be hard to tell, is it a voice problem or is it normal development? Are they just, going through some rapid puberty-related changes, or are they having a vocal injury that should be checked out? And I would say anytime there are concerns, voice problems that are lasting more than a few weeks, things that are not resolving, evaluation at a voice specialized clinic, and collaborative treatment with a speech language pathologist and voice teacher, as well as any other involved vocal professionals. So I have the Google search here because how do you find a voice clinic near you? I went to the Voice Foundation page and it's currently under development, so they don't have the list that they usually have. I was going to post that, but really making sure that you know who the professionals around you are. So being part of Voice Foundation is a big part of that, kind of being able to collaborate with your local, if you're an SLP, collaborating with your local choir directors, singing teachers, vocal coaches. And if you are a vocal coach, voice teacher, choir director, any of those, being able to collaborate with your local medical team. So I've seen a lot of different difficulties in young singers, but in my personal experience, the most common are actually muscle tension dysphonia. So no lesions, but muscle tension leading to more severe voice problems, followed by benign lesions of whatever kind, whether that's actually nodules or kind of these non-specific pre-nodular lesion-y things that are hard to pinpoint because they're not quite fully developed yet. And outside of the scope of this talk, laryngeal breathing disorders are really, really common in teenagers as well. And so something to just be aware of is these two things can interact. If you're having trouble breathing and you're having some voice problems, then you're also not able to get the respiratory control for singing. Kind of moving ahead, a little water. From the speech language pathologist perspective, I think for the voice evaluation, we're going to conduct a voice evaluation just like with a younger child or with an adult. But some things to really think about for teenagers is we want to get their perspective and their parents' perspective, and they may be different. And so, I always talk to the teen first and then ask the parents questions, but sometimes they may have different perspectives. But I always ask about their voice use, both singing voice use and other voice use, what kind of voice training they have, what their vocal aspirations are, and their vocal health outside of singing. For laryngeal visualization, I would always consider doing both rigid and flexible exams if you have that ability, because then you can examine during singing too, and you can look at what's happening with the laryngeal musculature and supraglottic configuration during singing. You can see what's happening. Your acoustic and aerodynamic assessment may be normal. There's a wide range of normal for teenagers, but also, all singers kind of have this ability to compensate. And so sometimes the numbers that we see look like, oh, that looks normal. So looking at where they're really struggling can be key. Dynamic assessment and stimulability testing. So figuring out what helps them is really important. And also showing where they're having trouble. Don't do an evaluation without having them sing. Have them show you where they're having trouble. And just because they come in saying that they only have trouble with their singing voice, looking at their speaking voice use and quality is really important. As with all singers, a lot of times they're more aware of what they're doing in their singing voice than what they're doing when they're speaking. So sometimes just assessing the speaking voice can go a long way to looking at ways to help improve things. Voice therapy should involve indirect therapy, counseling, expectation management. Vocal prioritization, I find, is really important in young singers. They want to do everything. Sometimes we have to say you can do anything you want, but you can't do everything you want. And you have to prioritize, especially within certain timeframes. If you're doing a show or if you're doing a NATS competition, you might have to prioritize that over other things. And providing education. So ideally, they've had good education about their voice in their voice lessons, but we have a lot of kids who haven't been taking voice lessons or who really don't know. So educating them about how their voice works, how vocal injuries happen, and how they can recover from them. And that it's not the end of the world if they have a vocal injury, that we have a lot of things that we can do to help them get back on track. The SLP's role in direct therapy, and I don't want to open a can of worms here, but I really believe that there is a lot of overlap between what SLPs and singing voice teachers do with the injured singer. But then we also, on both sides, need to know the limitations. So work with singing voice, apply to singing as appropriate and as your knowledge and skills allow. So, if you're not a singer and you are an SLP, you have a lot of vocal knowledge, but you maybe don't have the singing knowledge. And so you may need to look at that and look at what they're doing and recognize where your boundaries are and work with the singing voice teacher, whether that's actually like being in the same room together or, with how much we're able to use Zoom and other online platforms, collaborating that way can be a possibility. And really make sure that you are on the same page with them, that you're using the same vocabulary or at least translating your vocabulary with each other. So if you're teaching one thing and their voice teacher is maybe teaching the same thing but using different words for it, we want to make sure that they know this is the same thing. There's a whole team of people we collaborate with. And the voice team, I think of, the SLP and the ENT as being big parts of it. Voice teacher, vocal coach, choir director, theater director, bandmates if they are in a rock band or other kind of band, parents, other people. So it's not just a two-way collaboration. Often it's a multi-way collaboration, and that communication is really important and can be challenging. But I say communication is key. We all know a lot of things. None of us know everything, and an open dialogue between all the team members is really important in treating vocal injuries. So when I'm working with a young singer, I always try to figure out who else is helping them through their vocal injury. Is it just me? And if it is just me, where else are they singing? Do we need to talk with their high school choir director if that's the only other place they're singing? Do they need to talk with their bandmates if they're kind of doing everything on their own? Or ideally, if they're working with a voice teacher, then we'll be talking about, what do we see? What actually happened? When we see the strobe, do we see nodules? Do we see a lot of supraglottic compression? I'd want to share that with them if all parties are amenable to that. Of course, teenagers and their families can decide who they want to share medical information with, but I usually would recommend that they be willing to share that information with their voice teacher so that they know what they're working with and so that they know kind of what the limitations are. I tend to talk more about prioritization than voice rest and choosing how and when you're going to use your voice, using it in the healthiest way possible and knowing their own limitations, and working with the teenager to figure out what they can and can't do. That's all I have for my formal part of the talk. If anybody has questions or comments right now, happy to discuss, or we can open it up to Chadley and talk more later.
I didn't see anything come into the chat during your presentation there, Maia, but if folks do have questions, feel free to put them in the chat and we'll come back around to it. We can do Q&A after Chadley finishes. So thank you so much. I am so excited to introduce to you Dr. Chadley Ballantyne, who will be taking over at this point.
Okay, so I'll bring my share up. So I'm on the voice faculty at Stetson University, but before that, I taught for a number of years in Chicago, working with singers from middle school through high school, college, and beyond. And in particular, a large percentage of my studio were middle school and high school students. And I was fortunate enough to work with a population that included a lot of young professionals in addition to beginners. So I got to see a wide range of challenges that singers were going through and related to their growth and the growth of their instrument and the changes in their instrument and the growth and changes in the demands on them as performers and as singers. So a lot of my experience comes from that time, and now as a teacher of undergraduate singers, our program is undergraduate only. I work with primarily 18 to 22-year-old singers, but I also go out and teach sample lessons and clinics with high school choirs and middle school choirs throughout the Central Florida area. I'd like to acknowledge some of the people that I've collaborated with closely and whose work my work is very deeply tied to. Along with Ian Howell and Ken Bozeman, we teach the acoustic vocal pedagogy workshop. We had it this summer at the University of Michigan, and we're making plans for next summer. So Ken and Ian have had a huge influence on my work, and I really enjoy working with them. And then I had the great fortune of working with Karen Brunson as a co-author for her book, The Evolving Singing Voice. And the chapter on adolescent voice was my chance to get to write about my experience as a teacher working with adolescent singers. So just some terminology, which we covered a lot of this in Maia's talk, but sometimes as these acronyms might pop up on the screen, just a little refresher. And I'm sure these terms will keep developing and adapting and evolving over the years. So I'll briefly cover some of the things I have for ontogeny of the instrument through this age. Maia covered a bunch of wonderful things on this, and then I'll get into some ideas about what we can listen for as voice teachers. One of the things that I ran into quite a bit, especially with the young professional singers, was that their instrument was changing a lot right as the professional demands were ramping up. And it was causing their techniques to become unstable. The techniques they'd figured out or been taught as 8, 9, 10-year-olds that had got them started in the business started falling apart as they hit 11, 12, 13. And without proper guidance, they would find their own maladaptive ways to try to meet the challenges that they were facing. And a lot of the changes have to do with changes in dimensions within the instrument. So in particular, thinking about the length and bulk of the vocal folds, thinking about the portion that is vibratory, the portion that is not, so the cartilaginous length and the membranous length. As we go into this period of growth, the lengthening of the vocal fold allows it to be more adjustable, but it also means that it's a little bit pickier about the adjustments. The technique, the singing technique of a 10-year-old is much simpler than the singing technique of a 12-year-old because of these changes in length, changes in bulk, and changes in the diameter of the trachea. The airflow through a very narrow 10-year-old trachea behaves differently than the airflow through a slightly larger 13-year-old trachea. The membranous length of the vocal folds through this middle school adolescent time, the membranous length starts to become significantly longer than the cartilaginous length. So there is much more room for adjustment in timbre, in pitch, in phonatory pattern. And the instrument becomes much more reliant, as far as the singing technique goes, much more reliant on skillful balance rather than just direct effort. If the singer is going through this on their own, and right as they're starting to get more demanding professional engagements, their instrument starts becoming more complicated. What will often happen if they don't have helpful guidance or just the most brilliant rare instincts ever, will be to continually apply more force to the instrument, to try harder. And as they try harder, the technique breaks down more and it kind of spirals from there. What's really beautiful about this age, as scary as that is that now the instrument is really starting to take on the ability to learn, repeat, accurately hit adult singing technique ideas. So just a little chart of the growth rate for both the cartilaginous and the membranous portions of the vocal fold. It's fairly steady, but then there's that thing that we all know, the voice break, especially in testosterone affected voice change, where the leading edge gets bulked enough where it suddenly starts contacting more and dropping an octave through the middle school years. So we think of it as this very acute, sudden thing, but there's a pretty steady growth pattern to it throughout the childhood years. And here's that bulking, where we get bulking of the vocal fold, so it starts to make more of a mode, more of a thicker contact, more of a deep connection, and mode 1, and we get that sudden drop. I mentioned the airway, and this is something that still, even as a college teacher working with undergraduate singers, this impacts my work. The airway, the breathing system, hits its peak at different ages for biological sex females versus biological sex males. So the airway will continue to grow for biological sex male until about age 20. And for biological sex female, it's a little bit closer to that, 13, 12, 14 range where that airway is completely done growing. So a 14-year-old biological sex female soprano is going to be closer to adult proportions within the airway than a 18-year-old biological sex male baritone. And as a college instructor, it's something I keep in mind because sophomore barriers line up with right around that age 20, where the baritones and tenors are just hitting their peak or their adult finished growth pattern for their airways. That has an impact on resonance. So as the vocal tract lengthens, the formants descend and get closer in their dispersion. So we get a darker, deeper sound than they had at age 14. The breath control might still be something that needs to develop over that time. The longer the vocal folds are, the more finicky they are about adjustments. So that is a fun process. And what I found was, especially working with young belters and age 10, 11, 12, is right around this, my approach with using breath control, resonance work, very specific vowel articulation, resonance strategies for belting was a little hit or miss with 10-year-olds. And then by about age 12, it started to be something that was more repeatable. They were more accurate in repeating different movement patterns and hitting different auditory targets. So as I was going back and researching for Evolving Singing Voice, some of the things that came out in previous research that stood out was this kind of mesh point around age 13. Maia referred to this as well, of the neurological development and kind of corresponding with the growth in the body and also the formation of the vocal ligament. So one thing specific for singing is the speech motor control system hits adult levels around age 13. And as a singing teacher, where I needed to note that or allow for that was that an 11-year-old might be less accurate in repeating different outcomes. That some of the very fine-tuned things for belting and for classical singing might not be quite as easily repeatable for a younger singer. And as they started to approach age 13, I could expect that they would be able to hit particular vowel articulations much more accurately and regularly. And that the instrument, as we were going through this middle school age, this was the time to get in and teach skillful breath control, skillful coordination between breath pressure and loudness in the voice, skillful coordination between breath pressure and onset, and teaching the singers how to utilize the interaction of resonance and source, how to really maximize their sound through efficiency. So similar to the age groups that Maia laid out, I started kind of framing this as three big phases from the perspective of a voice teacher. And yes, I was a very fearsome middle school football player. So looking at ages, let me close this screen up. Okay. Looking at this 10 to 12, that the voice change is happening. Usually it's the average tends to be somewhere between age 12 and 13, but it's not always predictable. I've had plenty of students when I was teaching, a lot of high school students, that there was always at least one or two in my studio whose voices were changing around age 18. It was when they finally made that full drop into the adult voice. I'd say that was the exception, but it's fairly common. And to be patient and supportive with those singers, that each one reacts to that delayed voice drop in a different way. And you can listen for, as before the voice break has happened, you can be listening for instability in pitch, instability in loudness, listening for noise in the sound. Those are some markers you can be listening for, kind of keeping track of where the range is, where their average speaking pitch sits, and so that you can kind of track what kind of adjustments you might need to make, what changes might be coming up. So age 13 to 14, a lot of things are coming together here. Usually it's either the voice change has just happened, if we're talking about the very acute one for testosterone affected voice change, or we might be in the middle of the breathiest phase of estrogen affected voice change. There's an adult-like vocal ligament present by about age 13. The speech motor control is really starting to hit adult levels. So this also affects breathing, because that speech motor control includes pre-planning for breath. So having the intent to communicate an idea and taking nearly reflexively, or as part of this very complex motor pattern, the body taking an adequate, appropriate breath for the utterance that's going to be delivered. So thinking about how can we connect all of our musical ideas to speech phrasing, to emotional intent, to take advantage of that motor or that speech motor pre-planning of breath intake. As we hit age 13, 14, that they're most likely to be able to utilize these aspects of their instrument. And then getting into the high school ages, for most young people, as they hit 15 to 18, the voice change is more or less complete. The instrument is continuing to grow and continuing to develop, but usually starting to settle into a more adult-like instrument and result. I'll briefly touch on this. Maia had some wonderful slides about the descent of the larynx. And one thing to keep in mind is there's a secondary descent in biological sex male voice change. There's a secondary descent of the larynx. To my knowledge, at least it's been a couple of years since I've dug into this body of research, but to my knowledge, the cause of that secondary descent in the larynx is not completely understood yet, and it doesn't seem to happen with testosterone replacement therapy. So what that'll impact for singing is that where the larynx sits, it's going to change the length of the vocal tract and affect resonance. So when the larynx is higher in the throat, the formants are going to be more spread out and they're going to be at higher locations. So we'll have a higher, brighter timbre to the overall sound. And then as the larynx descends into the 20s, then we start to get the formants start to take on more of an adult pattern of a little bit lower locations, more closely dispersed. And then just a comparison of biological sex female vocal tract lengths and biological sex male vocal tract lengths. What's interesting and something to keep in mind, something that stood out to me as I was teaching, was that after voice change, the pitch range was quite different for young singers, that the locations of the resonances, as far as their frequency range, was not that different from singer to singer, and that for a voice teacher, knowing that this in an adult voice, so meaning post voice change, so getting into the teens, that the big break between the lower register, what we historically identify as chest voice, and the upper register, historical head voice, lands right around E4 for all adult voices. So near the bottom of the treble range, near the top of the non-treble range, and especially as young singers are getting into these teen years, teaching them how to navigate that change between lower and upper register, regardless of the vocal style they're working on. So what I want to go into next is thinking about functional listening and using some ideas from psychoacoustics to inform how we think about voice building and working within specific styles of singing. Like, what are we trying to enhance? How can we lay a foundation for vocal function, even when we're working with voices that sound young? What does a resonant voice sound like in a 12-year-old compared to resonant voice in a 32-year-old? What are some of the things that we can notice in the sound and how they can guide us in our work with singers? So I'm going to switch my share. Oh, not quite yet. I'm just kidding. I'll go fast. So the areas that I listen for as a voice teacher and coach my students in pedagogy to listen for are the pure low frequencies. So the very lowest harmonics, the ooh-like colors in the tone, the roundness and warmth in the tone, and compare that with, can you understand the vowel? In this second area, walking up from the bottom to the top, does the vowel sound clear? Can you understand what the singer is trying to communicate? Does it seem effortful or easy for them to use their diction, to get clarity in their text? Then listening for the presence in the voice. Is there an easy ringing present quality to the voice? And then are there any buzzy sounds in the voice? Is there a roughness to the voice? Depending on the style you're helping them with, we might want more or less of that buzziness. What does that tell us about the function? So as we listen up from the lowest frequencies to the highest, we can assume or we can notice that the low tones are very pure and ooish, that the higher we get into the spectrum, the rougher and brighter those sounds get. And as a teacher, as far as functionally, those lowest tones, that very lowest tone, the first harmonic or the fundamental frequency, that's the frequency at which the vocal folds are opening and closing. If you can come up with simple exercises to enhance that action, that partial, that fundamental frequency, you can build a lot of function into the voice and set it up for going in a lot of different directions as far as the resulting style. So this is a quick example so that we can hear all these squiggly lines and get on the same page, because I think this is easier to hear than explain. So this is me singing kind of a rock belt F4, and it'll go through in one pass of the whole sound and then break it down into these component parts so we know what we're listening for in the next step. for a voice teacher working with a lot of belters and a lot of talented young classical singers, it was really important for me to recognize that the lowest frequencies are very pure and heady. Especially working on building very strong belt techniques where we're taking a strong source and using resonance to interact with that source to create really loud, intense sounds that are repeatable and durable and sustainable. Convincing young singers or leading them to realize that the harder they push down in their instrument, the harder they try to sink down into the instrument and feel their belted tones low, the worse it worked, and that they could trust in building a very functional voice through very pure tones first, and then using articulation patterns, sequences of vowels to harness that pure sound and turn it into something with lots of intensity. That the low tones are pure, the high tones are the rough tones that are the intense, rocking, face melting tones, and that if you start with a pure foundation of those dark tones, that you can build all this much more powerful, interesting intensity through resonance and vowel work. Now let's head over to some adolescent examples. Okay, so I've taken these examples from Lynn Gackel's Finding Ophelia's Voice. So these are a few different examples at different ages. There we go. I just need to move my gallery screen. There we go. So these are a few different examples at different ages here. And we're going to pull these sounds apart. So we can start to notice, okay, what does the low pure part sound like? What do some of the brighter tones sound like? So this is an 8 to 10-year-old singer. And if we throw a filter in there, at first we hear that and it's like, oh, it's a little breathy. That's definitely a younger singer. We know that sound right away. What does the fundamental sound like in that tone from an 8 to 10-year-old singer? So can we start to notice the pure part in that sound? And what are exercises that could enhance that? If we take it away, maybe it'll start, and then add it back in, it might stand out to us. Then this is an example of a singer 11 to 13. Should be a good one. If we listen to just the fundamental, we notice again it has a very pure ooish quality. Teaching young singers how to sing a really resonant, efficient, easy oo vowel is a great place for really building a foundation for young adolescent singers. Without that sound, so that we can notice it, and now I'll add it back in. Then jumping ahead to a singer age 12 to 15. Filtering this so we can notice, okay, what does the pure part of the sound sound like? The frequency at which the vocal folds are opening and closing. What does that add to the sound? Oops. Hopefully I didn't just crash Voce Vista. We'll see. There we go. And also, what does the higher information add to the sound? So if we start from the bottom and bring it out, so we can start noticing some of the brilliance in the sound coming from resonance work. then looking at some examples, this comes from a performance from Peter Pan of Lost Boy that was posted on YouTube, just to get some examples of listening for the brilliance in more of a contemporary technique. So here it is all together.
Ever since that day.
And let's take this moment, because there's not a lot of accompaniment underneath it. It's kind of short, so bear with me. This is the entire sound. I'm sorry, it repeats so fast. But here's just that fundamental in that mixed belt tone. That fundamental frequency at which the vocal folds are opening and closing, is never going to sound like awe in the range of most belting songs. So can we build that? Can we use exercises that promote flow phonation and really enhance through nonlinear interactions the function of the vocal folds, and then use vowel work and resonance work to take that raw material and get all the brilliant sounds that are above here. And add the brilliance to the sound. The last examples I want to show are from a couple of my students these are recordings from their participation in chapter Nats events when they were in high school. So this was first year high school, I believe 14 years old at the time, singing in a classical style. And here's the note I wanted to excerpt. Here it is all together. So, age 14, learning how to sing, with independence of pitch, loudness, timbre. So, working on, as historic pedagogy describes it, a messa di voce. And knowing that this fundamental frequency, I have to put this in pretty tight because of the piano accompaniment, is supplying the warmth and the purity rather than it needing to be a lot of effort or manipulation to build this warm sound for a 14-year-old singer. It's about enhancing the fundamental frequency. There we go. And how that sound contributes to the overall warmth of the sound, and then how vowel work and resonance work can give us clarity in the vowels. And the ringing presence in the voice that allows it to really easily cut in an acoustic space. So I think I've used my time, but my goal here is to kind of open up our ideas about what resonant voice is like in young people. When I was teaching middle school and high school primarily, I used Voce Vista much more than I use it at college. What I found was that for adolescent singers, it was really useful in a very simple way. It was, for some of them, it was exciting to find out how their new voices worked. And for a lot of them, it was great just using it basically as a sound level meter. so that they could see and start to associate efficiency and freedom with power instead of associating pain and effort with vocal power. And especially when you're working with a very talented and precocious theater uh, population, that distinction of efficiency and skill and channeling emotion rather than pain and experiencing pain on stage is a very important distinction that sometimes is hard to sell. So having different tools available to you that can give them real-time feedback of when there's power in their voice, whether it's Voce Vista or other like a sound pressure meter or other tools to provide clarity and feedback, can be really valuable. So yeah, I have mountains more to say, but I'll stop there for now.
Thank you so much, Chadley. This was really fascinating. We have had a couple questions come into the chat, a few for Maia and a few for you. Since we're just talking about how you use Voce Vista, I'd love to answer these questions from Edie. Question 1, are you using the acoustics as a biofeedback for using the singer's physical performance to amplify their resonance, or am I misunderstanding? If you could just speak to that. And then is it
Sure.
all Voce Vista? Can you talk about Voce Vista a little bit? Edie said, I've never used it, so interested in your thoughts about it.
Yeah, so Voce Vista Video it was developed by Bodo Moss and Wolfgang Zaus, and now they are in collaboration with Donald Miller's original team. So this is the Donald Miller's Voce Vista and Voce Vista have essentially merged over the years. That was intended for quite a while. So yes, this is Voce Vista Video. What I find really helpful about it is the filter function. That was a big part for me working with young singers, was allowing them to hear those pure tones and the buzzy tones in their own voice, so they could start to associate the intensity and brilliance of pop belt singing with high resonance work instead of effortful pressed singing. So I would use it as biofeedback in the studio, and then for myself, I spent a lot of time just plugging things into it, finding audio, dropping audio into it to get a better understanding of resonant voices more than Dmitri Horostovsky. There's a big range of what could be considered resonant voice, and I think often when we hear that twangy, pingy sound of a 12-year-old, we don't necessarily identify that as resonant, even though it's quite loud. And starting to associate, okay, even though this is a much shorter instrument at a much higher pitch level, there's actually a ton of energy in this sound, and teaching their articulation patterns and more efficient use, like taking the patterns from speech, which work well enough for speech but do not work well enough for singing, enhancing those patterns and using this as feedback so that you can see immediately when it lights up by just shifting from one vowel to the other and starting to notice, like building their somatosensory awareness of their instrument.
Thank you so much. Going back into the chat, and then I'd love to open it up to folks who are in the room now. Janice asked, I think this is for Maia, how do you decide when to transition someone out of voice therapy and to a singing voice teacher?
It's kind of the million-dollar question, right? But I would actually say it's not a transition away from and into. I think it's more of a melding and collaboration, because, you know, we have a point where our I'm not going to just say rehabilitation, because sometimes we are doing habilitation with, especially with young singers who haven't developed some of these techniques. But when I involve the voice teacher as soon as possible, and then when I am ready to discharge them from the therapy, I want to make sure that they have a plan with their voice teacher. But I don't think it's a case of like, oh, they're done with me and now they go on to you. It's not like an either or. I think it's more of a gentle transition. And they may even come back to me, you know, once a month for some check-ins for a little bit until they're really ready to just be working on making their voice the best it can be, rather than recovering from an injury or preventing future injuries. Does that kind of answer the question, I hope?
I think so. Janice, you're the one who asked. Was that, yeah, she's nodding.
But it's so frequently the question of, well, how do I know when I'm done doing therapy and they need their singing voice teacher? And there's not a single answer to it. You know, we think in terms of, well, we are recovering them back to baseline function, but at the same time, especially with a teenager, there may not be baseline function. We don't know, they may not have ever had their optimal voice, so we may be kind of working them past where they were when they came to us, but I'm not working on preparing them for their role. I'm working on giving them the healthiest basis for developing their voice in whichever way they want to go with it.
Can I ask
ahead, Molly.
kind of a follow-up to that? As a voice teacher, if we have a student who is working with an SLP briefly, sometimes I found that they're afraid to involve their voice teacher with the SLP work. I mean, is it kosher just to kind of outright ask, like, which SLP are you working with? Can I reach out? Can I, see what y'all are working on?
I would highly encourage it. And usually I will ask the student, what voice teacher are you working with? And is it okay if I reach out to them? And sometimes they will say no, because they're embarrassed or frightened that they're going to have, there's still this, you're not going to refuse to go to your coach if you have a torn ACL and tell them that you have a torn ACL, but people will not want to tell their voice teacher that they have nodules or that they have something. And it's so important for the voice teacher to know that.
Thank you, Molly. There's another question in the chat from Edie for Maia. Could you address what are the most common diagnoses that you see in adolescents besides phonotrauma, like nodules?
I would say muscle tension dysphonia is absolutely top of the list, and that ties in with what Chadley was saying about how they don't always know that you don't improve your voice not just by powering through and pushing harder or squeezing harder or doing all of that, and then they develop these maladaptive muscle tension behaviors, which then can lead into phonotrauma, but don't always. Sometimes the vocal folds look absolutely beautiful, but their voice is not behaving the way they expect it to.
Thank you so much. I have a follow-up question actually for both of you, and then there's another one in the chat that we need to come back to. But for both Chadley and Maia, it sort of occurred to me that with all these rapid changes happening, and especially if you're also dealing with maybe another maladaptive practice that's come on top of all the changes, trying to suss out what is pretty tricky. And I wondered if you thought it would be advisable during adolescence to continue using new material, to not recycle songs that we sang 2 years ago with the way my larynx was configured 2 years ago, instead to continue always bringing new material. I have a lot of first-year college students who like to do that. They're like, let's go back to what I did when I was 16. And it has some problematic setup to it, just based on what both of you have talked about today. So what do you think about that concept of using new material, new songs?
Yeah, I'll jump in. Yeah, absolutely. Especially as range is changing through the middle school into early high school years. That's something I keep an eye on. And also as their musical skill set keeps improving. And so, yeah, I totally agree with that. And in my college teaching, I'm very careful about repertoire that they'll need as professionals versus repertoire we can use in those first couple of years to build technique, so that they don't get out there 10 years later and like, oh darn, I've got a bunch of bad habits in Toreador. Not that I'm speaking from personal trauma. So yeah, absolutely. And one of the things that that I found to be both interesting and helpful was for unchanged biological sex male voice, looking at, in particular, this came up with a lot of different voice types, but some of the examples that are coming to me right away were using, for one example, was using the song Burn from Hamilton, which is a female character, but using that for pre-voice change biological sex male working on their mixed voice and utilizing the lighter head voice falsetto moments in that song to make it okay to expressively sing in something beside just chest voice. And it really provided a gateway for us to work on more balanced registration for this young singer.
And I would even build on that. When we're moving beyond working with adolescent singers, when I work with injured singers, we will often try doing something completely new because their habits in their old pieces. It's really hard to come out of those, and sometimes they can go back to it later and then fix those, but you don't want to fix the problems in something that they're so habituated to.
Thank you both. There's a question in the chat for Chad from Natalie Ford. What resources are out there for learning more about using specific vocalese patterns based in resonance, voice truths, function for the adolescent voice?
So there are some listed in the Evolving Singing Voice, but the ones that I described there are adapted from Ken Bozeman's work. So I would really recommend for teaching resonant voice to young singers his Practical Vocal Acoustics, and looking at that, even though it's written from the point of view of someone working with adult singers, that those acoustic registration ideas that are laid out in there and the very simple exercises are applicable to all singers. And particularly as we get into the 7th, 8th grade years, as they're able to repeat these articulation patterns and hit these very precise movement targets, that's when we can really teach that. So they're really simple patterns teaching acoustic registration of lining up the first resonance of the vocal tract with the fundamental frequency, lining it up with the second harmonic, or letting the second harmonic pass through it. So those are like the three big areas, and the exercises are simple, and they're also the experience of acoustic registration that sounds like really esoteric and complicated, but it's happening, especially in lower voices, it's happening as soon as their voice drops. It starts to stand out. My memory of my voice change is being in 7th grade choir and sitting in the back row on a Tuesday afternoon around 1 o'clock in the afternoon, and I went from my voice had just changed that summer, and I was singing from ah to ooh, and the resonance changed in my head, and it scared the heck out of me, and I had a very vivid image of my voice disappearing into a well that was at the bottom of my chest. This is a very vivid memory. Okay, this is from 7th grade. It's about my only memory of 7th grade, except the time I got knocked out playing football. That sounds kind of personal and a me problem. But what I find is what I'd experienced now looking back, I know that I experienced an acoustic registration change of going from an open timbre ah vowel to a closed timbre ooh. Ah ooh. And that change in timbre and the somatosensory feedback freaked me out. And I immediately overcorrected to make sure that never happened again because it was so weird. So I switched from ah ooh to oh, and it never happened again. And that's not just my reaction to it. I teach that crossing of open timbre to closed timbre. Now I would suggest Ken's book, Practical Vocal Acoustics, for more information on what that means, if those are new terms. When I would teach just that very simple resonance work to young adolescent low voices, they would have similar reactions. They would giggle when it would happen. They would laugh. They'd be like, no, nope, not letting that happen, or that can't be right. And being there to reassure, and then, using Voce Vis to say, look, did you see this pattern change right where you felt the pattern change? I always use some vibrotactile ways of communicating that there's going to be a sensation change. So each of us singing into a balloon and noticing the pattern change on our hands as the timbre shifts. So then for treble singers, teaching them how to escape basically speech resonance and start to really focus their articulation so that the resonance really lays into those lowest tones. That's really different from speech, where it's about bringing out the high frequencies, so that because that's where the information is. And then in singing, use switching that over to really bring out the low frequencies, both to build function and to set up the warmth that we need for classical singing and for some of the deeper, fuller versions of mixed belt. But they're examples specifically to this in Evolving Singing Voice, and then a much more extensive explanation of the concept in practical vocal acoustics.
Wonderful. Thank you so much. I know we are past time, so if folks need to leave, that's completely fine. If both of our presenters are able to stay, there may be more questions yet, but I just wanted to give a blanket. You have permission to leave anytime if you need to. And thank you so much to everyone who's here. Are there more questions from the group?
I would actually like to ask kind of just a blanket question, but it's more of a advice of how either of you would suggest this. As someone who works with primarily, I mean, I would say 99% of my students are 18 and under. That is what I do. I am the kid teacher. How do you suggest that when you hear something, that you convince a parent or tell a parent, hey, I think it's time to go to an ENT. I think it's time to go to a speech therapist. I think we need to look into this because, I'm just a voice teacher. What do I know?
I mean, I can share my side of it. I would say, downplay the fear. So, don't go with fear. Go with, I'm hearing something and I can't see inside their throat just by listening. So I'd like to send you to somebody who can actually see inside their throat to see if this is just something that we can work through or something that you need more medical expertise on. So I would kind of say it that way. And when I'm talking to kind of talking to people outside of even singing, where they're kind of worried about maybe going to see a voice clinic. It doesn't mean that this is like I'm 100% sure something's wrong. This is I'm hearing things and I can't see what they mean, so I'd like you to see somebody who can.
Awesome.
Yeah, and I had a similar advice, and it was tricky for me when I was teaching a really large population of adolescent singers, because I was teaching in the school. So a lot of the times there are a lot of parents I never met face to face because I was seeing their kids during school. So some of the things I would check in on, I would kind of keep track of like vocal, like what did it compare to? Like, was their function getting worse over time? Was there periods of hoarseness that lasted more than 2 weeks? I would check in with them, like at the very first lesson. Each new student had one of the questions I would ask about are what sports do they play? So I had an idea of what their voice load was like outside of music. In particular, I found that basketball was one I had to keep an eye out for because the shouted instructions on a basketball court tend to be at speech level but just really pressed. And that tended to be the one that I ran into the most trouble with middle school aged singers. Even a little bit more than cheer, weirdly enough. Then I also wanted to know what other instruments they played, if they played any. In particular, flute and trumpet require a huge shift in breath pressure management. And then sometimes instruments like clarinet in particular might give them a very specific timbral target for these notes that is different from what we need in singing. Also, there are laryngeal adjustments in clarinet technique to manage airflow again to the embouchure and interaural breath pressure. So knowing what instruments they were playing, knowing what kind of things I would need to help them with in particular to those instruments. But if there was ever a moment where I was noticing, okay, they're ill, let's check in next week, okay, it's been 2 weeks. They seem to be getting marginally better. Okay, it's probably going to be okay. Giving them a vocal health routine to work with. So I knew, because I taught them all how to use a lot of semi-occluded vocal tract exercises. I made sing-along tracks for them. Talked to them about cooling up, warming up, cooling down when they were going into really heavy singing load times. So kind of having a baseline for whatever their baseline was. Um, but if it was something that was persistent past a few weeks, that was a sudden downturn in function, or if there were some things that they just were not responding to, like there was things that really made their vocal ability much different than that general population of students I was working with. That's something I started to keep an eye out for, and the conversation would go, I'm a singing doctor, but I'm not a doctor. And this is something that's been kind of persistent. I'd like to talk to your folks about, if it's possible to see a specialist, because that was the other delicate conversation. Is a lot of insurances didn't make it easy to see somebody besides a general practitioner.
Beautiful. I love it. Thank you.
Mm-hmm.
Thank you so much. Final call for final questions from the group. All right, hearing none, let's give a wonderful round of applause for Chadley and Maia. Thank you both so much. You have lots of gratitude popping into the chat as folks have had to leave. Really excited to learn here together, and thank you both so much. That was absolutely fascinating. And stay tuned, Alabama Voice Foundation chapter members. Stay tuned for our events coming in the next couple of weeks. And we hope everyone has a wonderful rest of their weekend. And especially for those who went to Fall Voice and joined us today, bravo, you've made it to the end of the marathon. We appreciate you. All right. Thank you so much. Chadley and Maia, if you have a moment to hold back, I have one thing to say with you. Thank you so much, everybody.